keratoconus. So what are the signs of keratoconus? You can see a progressive bulging of the cornea. Anterior corneal surface will bulge, and then slightly it will be below the center of the cornea. It's usually not on the center of the cornea. It's below, and it is probably situated a little bit nasally on the cornea. You can see. And when you ask the person to look down, the person will, that particular conical cornea will make a indentation in the on the lid, a margin on the lid, so that the lid becomes a little bit notched. When it becomes a little notched, what happens is you can see a sign called as Monson sign. And then cornea is first transparent vision, and then slowly, progressively, it will go into myopic type of astigmatism because of the shape of the cornea ectasia. So when myopic astigmatism occurs, you can see that it is the central part of the cornea diffracts differently, and the peripheral part of the cornea will refract differently. So you can see a fuzzy, distorted image for all the things. So this particular thing, you can see a Monson sign. Monson sign is the indentation of the lid with the pressing of the conical part of the cornea. So how do you diagnose a cornea? The easiest method is a World's type of lines are drawn. That's called a placido disc. It's a very old one. You project the placido disc onto the cornea, and if you see a nice cornea, you can see nice whorls, rounds on the placido disc reflected back. You can see through the center there is a hole in the placido disc. You can see like that. And another easiest method is you take the patient near to the window, and on the window there is a reflex. That's called a window reflex. That's easiest form to identify the keratoconus. When you see that through the from the window is reflected onto the anterior surface of the cornea. That will be very uniform in both the eyes. If you see any distortion in one of the straight lines of the on the cornea, that means the person will have a keratoconus. That's a very important thing, and easiest thing to know or detect. The person will be having astigmatic, myopic astigmatism, because the anterior posterior length of the eyeball increases a little bit. So for every diopter, you will get a 3 diopter increment. And then now latest is corneal topography. Corneal topography is the latest diagnostic method, where you can see the cone, where you can get a thinning, and then where exactly the thinning is there, the points, particular points will also be marked as color coding of red and blue and green. So green part will be usually in normal thickness, and then slowly it goes to the red. So what are the types of keratoconus present is it can be seen on corneal topography. It's a machine, and then in topography also you can see the distortions, whatever you can see. And the corneal thickness can be measured by an anti-segment OCT. That's called as ARM scan. ARM scan is the latest instrument which uses to measure the corneal thickness. So thickness at particular area can be measured with ARM scan. So all over the number of points on the cornea will be measured by the ARM scan, and then whatever are reflected back will be measured back, will be taken back and given a numerical value. So in such kind of numerical value, ARM scan gives a particular lower numerical value in that particular zone where the keratoconus is present. So this is a very important thing whenever you are going to do a surgery like a LASIK surgery for myopia. So myopia, if when you are going to do a LASIK surgery for myopic patients, what you have to do is you have to detect if there is any keratoconus forme fruste. That means it is not present but evident, but it can be detected by keratometry. So that particular thinness of the cornea, when it's present in one particular zone, you have to detect it early in order to do a LASIK surgery. So that is called a keratoconus forme fruste. That is an unmanifested keratoconus. That is the thing you have to remember. So when you are trying to do a retinoscopy with a plane mirror, what is retinoscopy? You got a source of light. There are two types of retinoscopy. One is a streak retinoscopy. One is a mirror retinoscopy. There is a Priestley Smith mirror is used, where there is a plane mirror with a small uh, pin hole in the center, say about 2 millimeters hole. Through that, you will reflect the light which is present at a distance. It will be reflected onto the mirror and in turn reflected onto the pupillary zone. When you move the mirror, the reflection of the light in the eye, pupillary area will move along with the mirror. So that is usually plus. When it moves against the mirror movement, suppose I move the mirror from left to right, the reflex will move from right to left. That is against movement is usually produced by minus refractive error of the patient. So minus refractive error should be corrected with minus lenses, plus refractive error or with the movement must be corrected with a plus lens. So if you see with the retinoscope, the keratoconus patient, you can see that it is not uniformly illustrated, but and the peripheral lights will converge, the central light will converge, and then the peripheral light will a little diverge, and then you will see a scissoring reflex. You can see the two reflexes, what by vertical and horizontal reflex will slap like that and move. That's called a scissoring reflex. So these particular people cannot be corrected with the regular myopic glasses. They still, you keep on correcting, they'll simply want more and more power, but they will not be able to see clearly with that eye. There's a keratoconus. So that is one important thing. And this is always invariably bilateral, but single side cases are not uncommon. Some people have high myopia in the right eye, left eye is emmetropic, or some people have high myopia in the left eye and right eye is not. Such kind of patients should be looked for keratoconus also. So refraction you cannot totally neutralize, or you can only get an arbitrary value and then you put the lenses and try to neutralize. Even with the best of the best neutralization also, you will not be able to correct fully the refractive error, so the person will not have proper vision. Okay. When you see with the slit lamp, what happens is invariably bilateral, as I told you, and the progress is rather slow. It onset will go from 15 years to about 20 years or something like that. It goes on till about 19 years or 20 years. We usually put as 90 years, the growth will stop in 19 to 20 years. So LASIK people, whoever are wanted to undergo LASIK or any refractive keratoplasty, you are required to mm, uh, till 19 years. Still the eye stops growing. So another thing, important thing is when you see with the uh, when you see with the um, microscope, that is biomicroscope is a slit lamp, you can see vertical straight lines. The small folds will be present at apex. These are parallel. These are called as Vogue striae. This is a very characteristic feature, and these are discrete opacities, slightly like small thread-like things in the stromal area, in the epithelial area. So that's why the thinning of the cornea occurs. Exactly, it happens on the in the center of the cornea, but the thinning is a little bit away, or probably on the less nasal side. So these things are called as Vogue striae. Okay, once sometimes they become confluent, and then what happens is they become a slightly opacified and can produce irregular type of refraction. Whereas it becomes like a nebulous type of refraction, like I told you, and it gives you a lot of irritation. And the brownish thing, probably due to deposition of hemosiderin pigment, which comes from, we don't know where exactly it originates even now, but it comes and deposits around the cone, base of the cone. The keratoconus. The cornea is there. There is a small keratoconus, small ectatic area. Around the ectatic area, the pigment will deposit. That's called hemocytic pigment. It deposits it encircling the cone. It is usually epithelial in nature and it's called as precious ring. KF ring is different from precious ring. So this is epithelial in nature. KF ring, which you see in uh, hepatic condition. What is hepatic condition? That that condition you can get that hepatolenticular degeneration or Wilson's disease. You get a KF ring that is usually at the level of desmus membrane. So where exactly the ring is, that is copperish white, copperish color, but here it is brownish nature. And you can see a brown ring deposited around the particular thing is called a Fleischer ring, Fleischer ring. So sometimes the desmus membrane also gives rise and gives off and then it produces small blips and they'll sometimes break. The cornea becomes edematous. Once there is endothelium problem, endothelium is supported by desmus membrane. When there is endothelium failure because of the breach in the endothelium also, when there is a desmus membrane malfunction, because of that, you can get a cornea becomes edematous, and then edema will give you small vesicles, and they rupture. These are called acute hydrops. When they acute hydrops, they produce a terrible pain for the individual. This is what you have to remember. So, what is the treatment? As the glasses are unable to correct, the treatment we usually imply is you take the correct readings of the glasses and then fit contact lenses. That is the easiest and simplest method to correct the keratoconus. So contact lenses also, there are different types of contact lenses there, you know. What are the most important and very popular contact lenses are usually the soft contact lenses. Or many of the girls will be wearing soft contact lenses for cosmetic reasons. But soft contact lenses are not proper to use in keratoconus because contact lens is so soft that the cornea will not take the shape of the contact lens. The contact lens will take the shape of the cornea. So the shape of the cornea alteration will remain to be the same because the contact lens will go and flap on the cornea and take that particular contour. But whereas you have to instill hard contact lenses into the eye. You put the hard contact lens or gas permeable contact lenses, rigid gas permeable contact, RGP lens. RGP lens. That is a semi soft lens and then hard contact lens. The cornea with the tear film, aid of the tear film in between the contact lens, the cornea will take the shape of the uniform contact. So any irregularity or any conical shape of that particular thing, apart from giving a, particular support to the particular cone, not to give away, and it can also arrest some part of the progression of the keratoconus. It also gives support. Because the support it does not progress, and then this particular cornea will take the shape of the lens, so all the irregularity will become regular. So this is the treatment which we offer for patients with patients with keratoconus. So the latest treatment has come now. This treatment is called the collagen cross-linking or CXR, collagen cross-linking. We had, everybody knows that cornea is made up of collagen, stroma is made up of collagen. So wherever there is an increment of the distance between the collagen fibers, there will be ectasia. That's a reason thing. So what we do is we have to link the collagen. So the fibrils will be linked by way of this collagen cross-linking. And this is a new modality, and it is this will also will be tackling the progression of the this keratoconus. So you are going to reinforce the corneal stroma. by linking. This is done by a small procedure where riboflavin of 0.1% eye drops instilled every 3 minutes or so for 30 minutes. So for half an hour, this 0.1% eye drops are instilled for every 3 minutes for about half an hour. And then what happens is remove the patient's epithelium should be removed. Epithelium will be scraped by putting a drop of alcohol in a small, there will be one small circle, a steel circle will be put, and then in that one drop of alcohol will put. And then after you put in the alcohol, you just gently scrape it away that way. And then epithelium is scraped, you put this riboflavin drops, 0.1% for every 3 minutes for half an hour. And then you expose it to the quantitative dose. That means the dose is quantitative. It's not quality, it is quantity. How much time and how many milliwatts of the thing will be given, that should be known. So 3 milliwatts per centimeter square, that's calculated, and a ultraviolet A radiation. It's not ultraviolet B radiation, ultraviolet A radiation is used. So remember, ultraviolet A radiation and 3 milliwatts per centimeter square is usually given. And then quickly the bandage contact lenses given to the cornea, and then drops will be given, and then he'll be discharged. This particular type of collagen cross-linking will form bonds with photosensitized oxidation to stabilize the corneal stroma. It won't allow it to give away. And delay in the progression, improve contact lens tolerance will also be improved. When there is a conical cornea, the nerves will be also exposed when there is thinning of the cornea. So that particular thing, contact lens intolerance will be there. That intolerance will also come down by doing this particular procedure. So acute eye drops, and it's giving rise to that particular vogue stray in the center of the cornea, and it's tooth in the cornea, you can't do anything. Such kind of cases, we do a most satisfactory activity, corneal transplantation or keratoplasty. So keratoplasty and transplantation and other things we'll talk tomorrow in detail. So this particular keratoplasty or deep anti-lamellar keratoplasty can also be done leaving alone the endothelium. So anti-lamellar keratoplasty will be done, and you will put a small patch graft, and then that's be all right. And the latest, still more, almost contemporary to that collagen cross-linking is intacs. Intacs అంటే intracorneal ring segments. So they'll, whatever the steep meridian is there, through the corneal stroma, they'll make a small opening, and through the opening, they'll insert that particular segment of a acrylic material into the cornea. So that particular material has got a certain type of rigidity. With rigidity, it tries to stretch the cornea that way, so that that particular peaking or coning of the cornea will come down. This particular segment is inserted in the upper part of the cornea and lower part of the cornea, and this will strengthen the cornea as well as make the cornea a little bit flat. These intact available rings are all beyond the scope of your things, but you have to remember what is latest. That is latest is intact. So when you insert intact, that is a reversible procedure. Suppose you did not get enough correction for your correction satisfactory. Therefore, you can take the intacts off and then try to reinsert in a particular different portion. So all these things will be computer managed, and the softwares are developed so that where is the steep cornea, where the cornea is flatter, you can put an intact or intracorneal stromal segments. Okay? This is what it is keratoconus is. There are number of signs, number of classifications, and what are the other things to do, what are the other complications of these ring segments, all these things are all beyond the scope of your undergraduate study. They're all postgraduate studies. We will not have to talk about them. So remember the keratoconus, keratoglobus, and pellucid margin degeneration. All three should be written if there is ectasia question. So the second thing is keratoglobus. What is the keratoglobus? Keratoglobus is a hemispherical protrusion of the whole cornea. Keratoconus is a conical protrusion of one particular area of the cornea, but here the entire globe-like protrusion, entire cornea will be a little bit tactile. It will just be like a bag. It will be just bulging. It bulges. What happens is you get usually it occurs bilaterally. It's familial. Somebody has a keratoglobus. You ask parents to come, ask the siblings to come. Usually you can see it is hereditary and familial in nature. And you have a differential diagnosis with ophthalmos. What is ophthalmos? Ophthalmos is oxide. It's a very big eye. Usually it is associated with congenital glaucoma. So ophthalmos you have to keep in mind. So when the intraocular pressure is so high that the eyeball becomes very elastic, uh, eyeball which is very elastic in nature, it can give away with the pressure of the intraocular pressure when develops in small iridocorneal degeneracies where the angle is not developed properly. The actually it produces a yielding of the entire cornea. It becomes very big. It becomes a megalocornea. But with the edema, that's called a ophthalmos. That is a differential diagnosis for keratoconus. And in that particular area, and with the rule, astigmatism will be present in keratoglobus, and the angle of the antechamber, and there is no cupping. The normal antechamber will be there, and there is no cupping like you see in glaucoma. You write down that keratoglobus is not associated with glaucoma. Congenital glaucoma, angle of the antechamber is normal, and there is no cupping of the optic disc. All these three things will be present in ophthalmos. Okay. Intraocular pressure will be normal. Then we come to the pellucid marginal degeneration. This is also so this is a painless bilateral corneal thinning affect the inferior part of the cornea. Painless thinning usually occurs at 4 o'clock and 8 o'clock. There is no conjunctival hyperemia. There is no lipid deposition. Nothing. Thinning is against, that is with the rule, this is against. Okay. When you do retinoscopy, with the rule and against the rule, you just go home and study that. You need to know about certain of the smallest conditions when you will be asked refractive errors thoroughly in your afternoon class. So read about with the rule and against the rule astigmatism. So sometimes there will be thinning of the slowly progress and against the rule astigmatism. These particular three conditions can be easily detected by corneal topography and orb scan 2. Orb scan 2 is the latest instruments. Then I can tell you something about vitamin A deficiency. What is the difference between vitamin A deficiency? There is also ectasia there. Vitamin A deficiency, you can see that particular ectasia, whatever it happens, the first year of life, vitamin A deficiency is an emergency. It is an emergency. You have to give injection of vitamin A, and it is usually bilateral condition. Though keratoconus is bilateral, vitamin A deficiency is also a bilateral condition. So it progresses so fast. The cornea is dull, very hazy, and yellow infiltrates. Totally all the tissue will be going into a melting type. It melts, cornea melts like butter. That's called as keratomalacia. So this is particular thing characteristic by the absence of any inflammation. So anything which happens without any inflammation, you suspect that there is a vitamin A deficiency for that person. So when you are seeing vitamin A deficiency, you have to quickly react. And treatment is ophthalmic emergency, child should be hospitalized, vitamin A should be given. So 6 months, retinal palmitate orally. So vitamin A is usually included in extended immunization program where they give a solution to all the children, all the small children, along with measles vaccine. So what does vitamin A do? Here, it fortifies the epithelial cells in the intestine so that it does not get any measles or any other gastrointestinal problems, etc. And 6 to 12 months, retinal palmitate, 1 lakh international units. So 50,000 is less than 6 months. Till 1 year, it is 1 lakh. And after 1 year, it is 2 lakhs. International units should be given. And total 3 doses are administered, And then second after 24 hours and third after 2 weeks should be given. After 24 hours and 2 weeks. So oil-based, vitamin A, A, D, E, K are oil-based. So usually it is oil-based solution. And persistent vomiting and profuse diarrhea, intramuscular injection need be given. Otherwise, oral vitamin A is sufficient for all these things. Okay, it is potentially blinding. So when it gives like this, the problem is that you have to act very quickly, externalize the eyes, and then give vitamin A solution, and then you can give an antibiotic, prophylactic antibiotic. It will be very easy for the eye to recover. That is diagnosed quite early. Beta hotspots, vitamin E deficiency is given as short notes or a long question for you in your examination. So you have to remember everything about vitamin E deficiency, keratomalacia, and all the corneal problems, and how you have to treat it. Prophylactic dose, therapeutic dose, all these things are given more in detail in your Qurana. Okay. And exposure keratopathy is another thing which I wanted to talk to you about today. What is exposure keratopathy? So you can, wherever there is any keratopathy, you simply say the cornea is hazy, and it can be due to any infective organisms or corneal epithelium is cast off. Cornea looks very grayish in color. So that's called exposure keratopathy. Usually, when you see patients with lag of thymus, visional palsy, and then neuroparalytic keratitis, these things will be, there will be absence of blink reflex. And the thyroid aortopathy also, you can see that the people open their eyes too much, there will be lid lag. In that cases, blinking is very much affected. Therefore, particular part of the cornea will be affected. That exposure keratopathy will be easily diagnosed by looking at the cornea. The lower part of the cornea will be more involved than the upper part of the cornea. Remember, the lower part of the cornea will get exposed, half closed eyes, because he is unable to close eyes properly, or blinking is insufficient. And this can occur in deep coma patients also. Patients will be half closing their eyes. Half of the eyes exposed. This is called exposure keratopathy. The treatment is usually given bandages to the eye with the antibiotic ointment. You can bandage the eyes. So and or sometimes it's a residual palsy is there, which gives to chronic exposure keratopathy. You can do a lateral tarsaroplasty where you make a raw area in the lateral part of the eyelids, inside of the eyelid. Then you can put a small suture reducing the palpebral aperture by producing a narrowing of the exposure. This is called exposure keratopathy. So these exposure keratopathy, remember that it's common, and anybody who is having any nerve problem or if there's any lag of thymus, and these are the importance you have to remember regarding exposure keratopathy, usually present in the lower half of the cornea. Then there is something called a neurotropic keratopathy and neuroparalytic keratopathy. So trigeminal nerve is a paralyzed, typically results in radical treatment of the trigeminal neuralgia. So it comes in neurotropic keratopathy is due to trigeminal neuritis. And then Gaussian ganglion, usually remove trigeminal ganglion injected with alcohol. Such kind of cases, you can get a disclamation on the corneal epithelial cells. Then sometimes it breaks down, it becomes cornea become cloudy, there'll be suprared infection, and then if it is virulent, you can get a iritis, reactive iritis, and then you can get a hypopan. So that also treatment is almost the same. Lacrimal puncta should be blocked so that the more of the lacrimal fluid will be in the eye and it does not produce dryness. So neuropathic keratopathy, I already spoke about this. And then photoophthalmia is a very important thing. You will be asked about photoophthalmia. Photoophthalmia is everybody, almost everyone is usually affected by photoophthalmia. Severe sunlight or especially the radiation comes to 311 to 200 nanometers, that particular radiation. It is usually snow blindness and photoophthalmia or day blindness. These things are usually written. Latent period of 4 to 5 hours between exposure and the onset of symptoms. So arc welders and then people who are going and skiing in the ice, etc., those people get a lot of reflection. Right? They need to wear Polaroid glasses or dark glasses. This is anticipated. These are called Crookes glasses, or they are cuts off nearly all the ultraviolet and infrared rays. These type of special glasses are usually, you can see skiers always wear type of glass very close to the eye. Those things are usually shield off the ultraviolet rays and infrared rays. So these things are very important to produce. This is snow blindness. Snow blindness is because of ultraviolet rays and this particular photoophthalmia is due to infrared rays. So these two things must be cut off. And if you see that anybody having photophobia, long time ago, in Vizag, the climate used to be very good. After a very, say, probably, say, in mid-80s or something, it is usually very good. It used to be very cold. When I went to Hyderabad, Hyderabad is very dry climate in those times. And when I went in midsummer, I developed a severe type of dry and photophobia. And somebody told me in Hyderabad that you have to visit the ophthalmologist, and I went there and he advised me cold compressors and lubricate nitro. Then only after using for 2 days or 3 days, I could get some relief. So I could get my work done in area office there. Just for a small information. So comfort from bandaging of the eyes, cold compressors, and also some cooling lubricating drops. That is very good for you. Okay. I'm sorry about the slides. I'll try to, I don't know, I'll be able to show them tomorrow, but I'll definitely post. I hope some of you will have my number. My number is 98491. Please write down 23790. The class representative can contact me and put his number so that I can put it in WhatsApp and you can post it in your group. Okay. Thank you very much. We'll meet tomorrow. That will be my final class. We'll talk something about the eye bank and some of the interesting things. Corneal degenerations, they are given in all the books so elaborately. I'll try to shorten it in such a manner that you will remember at least the names. That's a very complicated subject, which is probably not given in your examination, but you need to know. So we'll try to sum up the corneal degenerations fast, and we'll try to elaborate on eye banking and keratoplasty. Right? Thank you. Huh? 170 people వచ్చారండి మన తెలుస్తుందా మనకి
తెలుసు సార్ కానీ పీపీటీ పెడితే షేర్ లో వచ్చేదన్నమాట